Welcome to Black History Month, where the theme this year is Black Health and Wellness. I want to talk to you a little bit about what the Carter G. Woodson Lecture is. Carter G. Woodson is an educator, historian, publisher who founded the whole genre of African American history. Dr. Woodson was the only Black American of slave parentage to earn a Ph.D. in history. In 1926, Dr. Woodson developed Negro History Week. He believed the achievements of the Negro properly set forth will crown him as a favor in early human progress and a maker of modern civilization. In 1976, Negro History Week expanded into what we know as Black History Month. This holiday came about because Carter G. Woodson was disturbed that the history books largely ignored Americans' Black population. So Dr. Woodson took on the challenge of writing Black Americans into the nation's history. He established the Association of Study of Negro Life and History to do so. He also founded the group's widely respected publication, the Journal of Negro History. Black History Month is a powerful symbolic celebration, and it symbolizes, as always, it stands for something bigger. The critical role of Black history is pursuing racial justice and equality. Today, for our Carter G. Woodson Lecture, guest speaker is Dr. Yolanda Ogbolu, a neonatal FNAP, FAAN Associate Professor and Chair of Partnership, Professional Education and Practice at University of Maryland School of Nursing. She previously served as a Director of Global Health for the School of Nursing and as a secondary appointment in the School of Medicine, with extensive experience as a neonatal nurse practitioner. Her research and scholarship focuses on advancing health equity locally and globally. Projects centered around strengthening global health systems and nursing capacity, providing culturally and linguistically appropriate care, and addressing social isolation and social determinants of health in marginalized communities. She's been currently funded by the Robert Wood Johnson Foundation for 2 health equity projects. She is implementing the Belong to Baltimore study, which focuses on dismantling social isolation and addressing social determinants of health for families residing in historically marginalized communities in West Baltimore. Her other grants focuses on developing a network of researchers to expand the field of global learning to advance health equity. This project is a collaboration with colleagues from Detroit, New York, Navajo Nations of the Southwest, and Athens, Ohio. Engaged in public policy and policy advocacy, Ogbolu leads a state-mandated task force on social determinants of health in Baltimore and has served on task force to reduce disparities in newborn outcomes and improve delivery for culturally and linguistically appropriate care to diverse populations in Maryland. She's a graduate of Baltimore City Community College, Georgetown University, and the University of Maryland, Baltimore. Dr. Ogbolu is a fellow of the National Academies of Practice and Academic American Academy of Nursing. She's also a proud Baltimore native, wife, and mother of 4. I'd like to welcome Dr. Yolanda Ogbolu as she presents our Carter G. Woodson Lecture on advancing health equity locally and globally. Welcome, Dr. Ogbolu.
Thank you so much, Dr. Savoy, for the wonderful introduction. And I'm so excited to be here with you today virtually. I would have loved to have been there in person, as well as I'm very familiar with Coppin University and look forward to an opportunity in the future to be there in person. I think I'm going to start by sharing my slides once I'm able to stop the previous ones. Great. So I'll start with, doesn't this always work this way? Hope you're able to see the slides well. Didn't work. Okay, great. So thank you so much for having me. As was mentioned in the introduction, some of the projects I'll be talking about today are funded by the Robert Wood Johnson Foundation. So I'd like to acknowledge them for the funding they provided to the work that I do around health equity. As we start our journey today, I wanted to talk a little bit about my personal journey and then give a brief overview of health equity in general, and then jump right in and really share two examples of health equity in action. So I'm a native of Baltimore. I worked for 25 years as a neonatal nurse practitioner, and I've been really excited to transition after 25 years to academia and work as a nurse educator and scientist, while at the same time focusing on health equity policy and being an administrative leader. I shared like this quick snapshot of myself because as I'm sure there might be students and others in the room, I like to say, as we think about our story often drives our passion, it drives our leadership styles, and it also eventually drives our future trajectory in terms of where we're going. And so I think from my presentation, you'll have an idea of how I grew up has shaped the person I am today. So I grew up in Baltimore, and I love the city. I believe it's a beautiful city. I still have 200 family members that live here. My family's been in Baltimore for 8 generations. And so I have a lot of memories growing up in a row house initially in Baltimore. And I remember we used to clean the steps like it's depicted here in the picture, because we wanted to win a prize. It was a prize that was offered by the Afro-American newspaper for keeping your block clean and safe. So every year they used to have the contest, and the winners would have a big block party. The street I grew up here, I was really fortunate. Neighbors looked out for each other, and we were relatively close with our neighbors. And I still have some friends that I grew up with on this block. Unfortunately, where I grew up, my income was pretty low. And ultimately, we ended up in this other picture that's on the right, on the top. We ended up living in Lexington Terrace in the low income housing in Lexington Terrace. And this picture in front of the high-rise building that's in the center was my elementary school. So I went to elementary school there, and we lived in the projects until I was in middle school. And it was here that I began to understand inequity. I couldn't give a word to it, but I wondered why everybody that lived in the building that I lived in, we all looked alike. People often seemed to be struggling for food. And I was just a kid, and I couldn't I wouldn't have called it inequity. But as a kid growing up in this community, I did begin to wonder why things were different. This is Martin Luther King Boulevard. If you look on the other side of Martin Luther King Boulevard was University of Maryland, where I work. But looking at University of Maryland as a child, it's a bit surreal now for me that I worked there, because people that lived in my building just didn't work at places like that. I have, grew up here. I began to really think about inequities. I began to be curious as a child why things were different. I went to nursing school, became a neonatal nurse practitioner, and in the hospital, I saw the same thing. I saw very often that babies that were in the neonatal intensive care looked like me. And I began to wonder why babies continue to be born premature and why we couldn't look upstream. There's a public health parable that says I'm at the bottom of the stream, and these babies keep coming down, and they're sick. And I wanted to go upstream and better understand how to prevent babies from having to come to the NICU. And that opened up this big vision for me to become what is called an upstreamist. An upstreamist is somebody that's just really like, okay, let's not just focus on the down causes of why babies are dying, but let's look at the bigger picture. At the same time, while I was working in the neonatal intensive care units in Baltimore City, I was invited to go to Africa to teach newborn resuscitation. It was something that, you know, I had learned as a nurse and thought I could share with nurses and other health professionals in Africa. And I had been invited, and I thought maybe if I could, you know, make a difference, if maybe I could save one baby by going to Africa. But one of the things I learned by going to Africa to teach neonatal resuscitation was 90% of babies that die all over the world die within places like sub-Saharan Africa and Southeast Asia. And to me, I began to understand that these inequities were not just in my neighborhood, it was an issue that was happening across the globe. And it was something that I had hoped and dreamed I would be able to have an impact. So while I didn't have the words for it when I was younger, there are words for health equity, and the World Health Organization has defined it, as well as Robert Wood Johnson and National Academy of Sciences. And we know that equity is the absence of things that are avoidable, unfair, or unjust. And these are the things that prevent every single person from having a fair and just opportunity to have a healthier life. When we think about health equity, it requires removing things like happened to me when I was growing up, things like poverty, discrimination, and equal and fair pay and quality education. And we know that these things are not easy, but it is possible to make change. So when you think about equity, I love this diagram that is from the Pennsylvania Health Department. And if you look at this picture on the right, you can see where they talk about inequality, and inequality is when we don't have equal access to opportunities. And if you look at the picture at the very top, you see there's this tree, and it's leaning, right, disproportionately leaning to one person that is able to just kind of get these apples. They're not working for them. These apples are just kind of dropping in their lap. And then you can think about this as equality. You know, you might hear people say all the time, I treat everybody the same. I treat them equal. But is being treated equal good enough? Is a question we have to ask ourselves. When we look at equal treatment here in the diagram, both of the children have the same ladder. But if you look at the child on the right, you know, they still can't reach the apple, and the apple is still skewed to the other side, right? It's leaning disproportionately to the person that is able to get more. So when we talk about equity, we talk about giving everybody a fair and just opportunity to really be able to access what they need. And that means we might have to customize tools so that everybody can reach the tree and have a fair chance of getting it. But now we know just equity alone is not enough. We really need to move towards a model of justice where we actually fix the problem, right? So if you look at the very bottom here, we straighten up the tree. And we make sure that both people can reach the tree and be able to have an equal opportunity for health. So for my career, I've tried to focus on the root causes of inequity. I have been less likely to focus on disease specifically because as many of you have probably attended lots of health equity talks, generally you see lots of maps And whether you're showing an infant mortality map or a heart disease map, it seems that all of those health disparities, differences in health outcomes, they all happen in the same communities within Baltimore. And part of that is because we haven't addressed the root problems, the root causes. And so I believe that addressing the disease alone is not enough. We have to really focus on the root causes of inequities. And one of the ways we can do that is by addressing what's called the social determinants of health. These are the social factors or the conditions that impact our health, right? It has to do with the places we are born, where we grow up, where we go to church, and a wider set of forces, even political forces that are shaping the dynamics in which we live our daily life. And so it's things like our income, whether we're exposed to adverse childhood experiences, and access to healthcare services. So I believe that we all have an important role to play in addressing the social determinants of health, that we know that your zip code, where you live, if you type your zip code into this web page that I listed at the bottom of this slide, you will find that your zip code is predictive of how long you live. And we know that people that live within the poorest communities are at the greatest risk for worse health outcomes. So I hope you will take your time to look up your zip code. But the important point is we all have a role to play. When we think about addressing social determinants of health, especially when we think about it within the health sector, it's not that people are not addressing social determinants of health in the health sector. For the most part, people are, and nurses and physicians and other health professionals are trying to understand and acknowledge the social context in which people live. For example, we would not send somebody home on a medication that requires refrigeration, hopefully, if they didn't have a refrigerator. We try to tailor care and tailor the plan of care to the social context. And we try to really change the way that we deliver care. The real challenge with addressing the social factors that impact health in the healthcare system is that it's inconsistent. It's not done every day with every provider. Often it's not part of the protocol, and it's not routine and systematic. And if we really want to make a difference, we really need to make it systematic. Some health professionals are uncomfortable with collecting social determinants of health data. You have to ask some really difficult questions about people's lives, and that can be uncomfortable. But collecting that data is really important because it allows us to do what I call social determinants of health targeted care, which is something where we focus on how do we change the social context? How do we change the social context in the way that it can inform public health policy? How can we use data in the hospitals and in healthcare systems that show many people don't have housing to advocate for improved housing and other community and clinical resources within the community? So when we think about health equity, many of us that have been working in this space for a while, we recognize that health equity has a long way to go. For many people that are living in communities listening to me right now, they might say, yes, we really have a lot of work to do. We've tried a lot of different things, but we haven't addressed the root causes. And perhaps because of my years of experience in global health, one of the things that I've been really interested in is to what extent can global learning be part of the toolkit to help us better advance health equity. And so I'm really interested, for example, in how we can take ideas from around the globe that to improve health equity, not only in America, but improve global health equity. And we'll talk about that a little bit more. As part of that work, and it was mentioned earlier by Dr. Savoy, I am working on a project that is developing a national network of researchers that are interested in global learning to advance health equity. So why would I think about bringing a global idea to help advance health equity in America? And perhaps this is, as Nigel Christ writes about in his book, Turning the World Upside Down. Because I think it's really important for us to recognize that despite advancements in technology and the US being a leader in terms of improving health, the United States has worse health outcomes than its peer countries. When we look at 10 other high-income countries for medical care and for health outcomes, the US has performed less well on many population health outcomes. So it led me to have a question about whether learning from the globe could help assist with addressing health disparities in the United States. And I began to ask the question of what can we learn from other countries that could improve the health of local populations in the US. So for me, there's been a personal shift. And there's a shift to this model of what I call bidirectional learning, because I believe that all of us should have a fair and equal opportunity to access the best evidence about how to improve health from around the globe. And so I focused much of my work recently on what I call reciprocal innovation. For the remainder of my time, I want to share some information on two of the projects that I've been working on to address health equity. One of them is focusing on this idea of global learning and is focusing on a project from Brazil to Baltimore. The other one is to share some information about my health equity work, specifically the social determinants of health task force work that was mentioned in the introduction. So I'll start with telling you about the project that I'm working on that's called Family Social Inclusion Global Learning from Brazil to Baltimore, about the journey I've been on this project to dismantle social isolation in Baltimore and to address the social determinants of health with a specific focus on mothers. Social isolation has become a household name with the COVID pandemic. All of us have heard about it. All of us have probably personally experienced it. But I began to think about social isolation before the pandemic. I remember growing up in Baltimore, I felt isolated as a child. I spent most of my time in the library, which is probably why I ended up reading a bunch of books and am able to be before you today. I wondered if children and people in Baltimore felt socially isolated. You know, lots of attention before the pandemic have been given to older adults living in communities, and it's well documented that older adults are isolated. But little attention had been given to the impact on mothers and children, particularly mothers and children living in marginalized communities. I was interested in this because Research shows that social isolation is just as dangerous as smoking 15 cigarettes per day. It's as dangerous as hypertension and high cholesterol. Further, if you're isolated as a child, research shows that people that were isolated as a child are more likely to die 20 years earlier than those that did not experience social isolation. So given the emerging evidence related to social isolation, I think that addressing social isolation early in life with families could benefit public health and well-being for generations. And so my work builds on a partnership that I had in my global health work with Brazil. And my travels to Brazil, I noticed that they had a program that was working to break down social isolation and to promote social inclusion. And I wondered if this program would work in Baltimore. One of the reasons I thought it might work was because there are similarities within the two cities. Within Brazil, they have something called favelas, which you see on the left, where marginalized communities live and suffer almost the same health outcomes as many people that reside in Baltimore. They have lots of similar outcomes, but they have lots of also resilient individuals that have grown up in communities that were notoriously historic for some of the positive work that they've done. This study focused on transitioning a program from Rio de Janeiro in Brazil to West Baltimore. So what is it? The program recruits families from the health system, and it works with families by doing a baseline assessment of social need. And then they develop a family action plan and provide them with a monthly coach, and they address social determinants of health over 2 years. When I came to Baltimore, of course, this idea is not something I would have entered into without community believing in it or wanting it. So one of my first efforts was to go to community partners, to talk to community members and to see what their thoughts were about whether a global program would work, and also whether social isolation was even an issue for their community. And so we partnered with all of these organizations that are listed here to really implement a study that was implemented in 2 phases. The first phase was really talking to community members and understanding their perspective. And the second phase was adapting the program based on the community feedback and implementing the program in Baltimore City. And so when we spoke to community members about social isolation, we had some really good but painful discussions about social isolation. And the community members confirmed that social isolation was a challenge for them. They felt that social isolation was embedded in a lot of different things that were happening in the community. For example, these are 2 of the statements from some of the participants. They said a lot of things scares us. It makes us not want to go outside. And then somebody said they fear they'll be caught up in somebody else's mess. And this is just a snapshot because community members recognize that they were experiencing social isolation. And again, this was before the pandemic. They recognized that they were experiencing social isolation, but they also offered lots of solutions and positive feedback on how to resolve it. Our project really focuses on using a continuous community engagement process. I believe community members are the expert on what they want in their communities. that they have the power and do take ownership of what's happening in the community, and that they have solutions. And this was really true for this project. And community members can transform the community and bring forth hope and pride. So for phase 2 of the study, we tested the adaptive program, and I'll talk to you a little bit about the outcomes. We replicated it very similar to what they did in Brazil, with some changes based on community feedback. For example, we had initially planned to work with children 0 to 3, and the community asked us to go up to age 5, which we did. And so we recruited families from Baltimore. We developed a family action plan, and I've been very fortunate to have a strong team of community health workers that work with families to provide monthly coaching and support groups over the past year. These monthly support groups, as you can imagine, we started before COVID, but within COVID has been very rewarding for the community members, for the families that we've helped. Over the 12 months, we have really deep conversations within these support groups. We talk about things like how to set a goal. We help them to identify their strengths, teach entrepreneurship skills, and we don't shy away from difficult conversations as it relates to racism, how to have the talk with your child about racism, and also how to deal with interactions with the police. We bring in a multidisciplinary team and community members, including bringing in police officers to really have real conversations with community members. So let me tell you a little bit about what we've learned. Most of our participants have been about an average of 33 years old. They've been mostly women. They've been mostly non-Hispanic, Black, and many of them have at least a high school education, and a lot of them have college educations. One of the first things we do is to assess their social determinants of health need. And we learned that their greatest need was related to food and housing. We also measure their social network. In terms of measuring their social network, we have something that we do that is really interesting. We ask them, like, who's in their inner circle? And these are people that are really close to them, people they can't live without. We also ask them who's in their middle circle, as well as who's in their outer circle. And one of the things we learned is that many of the families participating in our study had a small network size. Most of them only had 9 people in their network, but the people they had in their network, they were really close to. So 85% of them had really tight connections. One interesting finding was most of the participants reported that their neighbors were not in their network. In fact, the neighbors only accounted for 2.8% of their network. So none of us really get to choose what social network we're born in, yet we know that who you know and how many people you know does matter. So when you think about social isolation, you can also think about it as deprivation of social connections. One of the interesting things we found out that we were really excited about right from the beginning was we measured participants' hope. And we learned that as people were more hopeful, their stress and their anxiety was lower, and they had less social isolation. So as you can see, many of our families did experience stress and anxiety, but they also were pretty hopeful as well. When we looked at our program after 6 months of intervention, we found that people had a reduced social determinants of health need as it relates to almost every category. They reduced their social determinants of health need for housing. As you can imagine, our community health workers were charged with helping people find resources and link them to resources, as well as follow up with them to see if they were able to obtain those resources. And so that really made a difference in reducing housing need and other challenges that people had in their house. We also were able to reduce social determinants of health need for food. We had less families at 6 months reporting that their food would run out or that their food would not last the whole month. When we talked about transportation issues, many of our families, when they set their goals, they wanted goals to get driver's license or to get be able to purchase a car, and they were able to reduce their transportation issues. One of the things that was particularly troubling to us at baseline was we had several families that reported that they were threatened with harm. And that created an emergency for us to be able to get them linked to appropriate resources. And I'm happy to say by 6 months, we had no families that were actually threatened with harm and had really utilized those resources. When I looked at social isolation, one of the goals of our program was to reduce social isolation, but who could have predicted a pandemic in the middle of this? So we studied social isolation before and after. And at baseline, our families had pretty high social, well, they had social isolation that was a little bit higher than the US average at 51.5. And at 6 months in the middle of the pandemic, their social isolation was even higher at 54. One of the things that we talked to community members about, and maybe I skipped that slide, was when we talked to community members, they said it's not social isolation, it's situational isolation. It's the situation within our communities that is really driving us to stay in our homes, not talk to our families and friends. And so we developed a situational isolation measure. And one of the things we did note after 6 months into the study was that the situational isolation was decreased, although the social isolation measure did not. Families also had reduced anxiety and stress at 6 months. And when we talked to community members, some of the things that they said that might resonate or be meaningful to you, as people said before they came to the program, which we fondly call B2B now, or Belong to Baltimore, people said before I came to Belong to Baltimore, finding social resources to help me and somebody to really help me was like searching under a rock in the middle of the ocean. And another participant said, just having a family navigator, this is the community members that are working on the study, having them check up on me, give me advice, has really helped me to stop, focus, and think about what I really want to do. So we've so far had high acceptability of the program. The program is still in progress, but we've learned a lot from community members. We've learned that community members have the power to make a difference in their own lives. We serve as facilitators to help community members, but they do the hard work of addressing their social determinants of health and dismantling social isolation. We were fortunate to have a good opportunity to build trust with the families that participated in our study. We were able to build that trust in part because of our community partners, but really in part because we worked with community members and let them take the lead on the study. When I think about our study and our team, I'm forever grateful for the team. But it was interesting that, you know, our families and our community members have the same challenges we have. And so I think we were able to provide empathy and compassion for the families because many of us had already experienced social isolation. We had experienced many of the challenges people had experienced, whether running out of food or struggling with work and housing. And so it allowed us to really have deep and meaningful relationships with family. We made the meetings fun. We had a family member last week that was finishing up her 12th month. And she said, you know, this really didn't feel like a research study. It felt like I was coming every month to meet with a group of women, a group of female supporters, and that really felt good to me. So I think the program is strengthening social inclusion by building these trusting relationships. I think the methodology that we're using, having community health workers take the lead, is really making a difference. When families come and meet with us every month, they tell us about the challenges in addressing social determinants of health, and we're able to help them break down barriers to inclusiveness so that they can have their needs addressed and improve their health. So this is the study team. I see we have one, at least our program manager, Janet North Kabor, is on the line. And, you know, I'm forever grateful to the community members. Most of the community members have lived in Baltimore in the past or currently live in Baltimore. And I think that was really important. We also have several collaborators outside of the School of Nursing, including the School of Social Work and at Hopkins, that I'd like to acknowledge. So feel free to connect with us on social media at Belong to Baltimore, which is the study's name, and or ask for more information. So in the next 5 minutes or so that I have, I do want to share just one more quick example around health equity policy, a potential action, another way that I hope all of you would consider acting. So I've been fortunate to be the chair of the Social Determinants of Health Taskforce of Baltimore City, along with my co-chair, Dr. Chris Gibbons. The Social Determinants of Health Task Force of Baltimore is really an interesting project because it started as a grassroots project. In 2015, former Senator Shirley Nathan Pulliam, who's depicted here with the scarf, she convened a work group made up of many people from academia, from community members and community organizations. And she said, you know, we should work together to understand how we can address the social factors that are preventing families from thriving and being healthy in Baltimore. And so we worked together since 2015 to really think about how can we bring people like urban planners, police officers, and all of us together to think about how we could identify solutions to address social factors. And so we worked for about 5 years, and then from a grassroots work that we did, Senator Pulliam then submitted a bill 444, which passed and signed the Social Determinants of Health of Baltimore City Task Force into law. And you see, this was at the signing with Governor Hogan. So the Social Determinants of Health Task Force is composed of 5 subcommittees. We focus on health, housing, education, social justice, and workforce and jobs. And those 5 areas were provided by community members through interviews. They said these are the things that are important to them that they believe would help improve health. And so we're really fortunate to have a large number of people that work on the task force. And this is just a quick overview of who they are. I would like to give a shout out to the co-chair of the Health and Human Services Subcommittee, Dr. Denise Waddies Daniels, who is also faculty at Coppin. The Social Determinants of Health Task Force has done a variety of work in these 5 categories, including the study on social isolation that I just talked about, a comprehensive review of housing policies and practices. Also, we had a couple of community meetings around online education as we were working online during the COVID pandemic. And then the Social Justice Task Force that has been really active in voter registration and voter engagement, as well as working with community organizations like the Holland Park Community Organization to improve that community. And then the workforce development has been really active in starting a workforce development program by working with churches to develop technology training programs for youth. During COVID, we convened emergency meetings and a work group to ask what we could do as a group to address COVID. And we partnered with faith-based institutions, churches, and we had several community members come in to share about what they were doing to address COVID. The subcommittee, the task force has two responsibilities. One is to look for practical ways to address health equity. The other way is to make policy recommendations. So much of what we do has to be done through policy advocate. And so we've advocated, for example, for bills that address racism as a public health crisis. We've advocated for mental health initiatives within schools and for expungement policies for people that are returning to home from prison so that they can be able to get a job. The goals of the task force is really to support the community's work and to allow community to take the lead and to avoid duplication of efforts as we try to put forth practical and policy efforts. And so this is just a little snapshot of some of our meetings where we've connected with community members. And this is a copy of our email for some additional information. So as I wrap up, I want to say the landscape of health and healthcare is changing rapidly. We need innovative approaches to address health equity. I believe global learning is just one innovative mechanism that could be used as part of a larger toolkit. I believe that health equity policy is critical to breaking down structural barriers to health, and that people should not forget that grassroots efforts can make a difference. And finally, that health equity is everybody's responsibility. And I hope that you will use your story to do your part. Thank you so much. And I welcome questions.
Yes, we did have a question in the chat area, and let me see if I can get it. Can you provide us with the SDOH? Can you provide us with the zip code that you were talking about?
Sure. Yes, I will. Put that in the chat.
Any other questions? You can raise your hand if you have any questions. I have a question. As you were talking about social isolation, were there any virtual support networks to assist in this particular endeavor?
Sure. So for the, when we initially planned this project to happen in the community, we were planning to implement the study at a church, face-to-face with community members. Obviously with COVID, everything shut down. And so our program was implemented online. We met with families online. They were able to use their telephones. Fortunately for us during COVID, many families received increased access to the internet, as well as computers at home. And that really helped families to be able to be engaged and participate in the study. So they met with our team 2 times a month. The first time they met with the community, the first time they met, we met in person, and then we would meet again on a phone call.
Okay. Did you also find any families that were dealing with any disabilities during social isolation?
Yeah, in terms of disabilities, it is something that we asked about as part of our survey. And it depends on how you define disability. But of course, we knew that one limitation to this project is that some families that didn't have access to the internet would not be able to participate. And I see that as, something that we couldn't prevent because of COVID. We would have offered it face-to-face, but ideally, it would have been great if all families could participate. So that was a limitation. People did report learning disabilities. People reported issues with mental health. A fair amount of our families did report mental health challenges before the study.
We have a question from Dr. Arian Tatum. Please discuss any lessons learned or anything you and your team would do differently.
Sure, thank you so much for that question. I mean, from our families, one of the things we learned is that they would have loved to meet with us face to face. So if I was able to implement this study again, which I hope to do so, I would love to have an opportunity to implement it face to face. In so many ways, the virtual environment helped us because many parents didn't have to worry about childcare. They didn't have to worry about transportation, and they could still participate in the study. But at the end of the study, when we asked families what we could do better, one of the things they said was meeting with us face to face would have really made it even better than what it was. So I think that's one lesson that we will walk away with.
Great. Are there any other questions? You can type in the chat if you have any other questions. I do. So this is an anonymous attendee. Social determinants of health has been presented as a solution to inequity, but there is concern that using a disparities lens, oppressed communities are tactically forced to adopt the beliefs that what health looks like is mirroring the dominant population. What work have you seen using social determinant lens, which challenges the notion that oppressed populations should mirror dominant populations as their model of health? And are we seeking to build alternative systems owned and controlled by oppressed people?
Sure. So thank you so much. Another great question. I think really one of the strategies we use in our study is a continuous engagement, community engagement strategy, really focusing on community power and community ownership. Going to the community before we implement a study to make sure that this topic resonates with them, and being willing to back down if it doesn't resonate with them. And so there's no movement in terms of, when you think about social determinants of health and health disparities, you could think about it in a lot of ways, but I think using the community power model makes the community front and center in the work that we're doing, in terms of using kind of a white normative theory as a model of where we're trying to go. I don't think that that is what we're doing in our work. And I think there are many people that are not using that model. So if I understand the question that you're trying to say, I do believe that a lot of health equity work looks at things from a deficit lens. And I would agree that it's really important to look at things from an asset-based lens and help people understand the assets of their community. In this study, many community members said, we don't have the resources that we need in the community. Through our study, we were able to help link community members to resources that they do have in their community. They didn't know that those resources were available to them, but we were able to link them to them. This study, one of the things that we did from phase 1 to phase 2 was we shifted from social isolation discussions to belonging lists, to belong to Baltimore, because we thought it was important to build a sense of community belonging. And we did get some questions from people, negative comments about shifting to belong to Baltimore. Some people couldn't resonate with this sense of pride that we wanted people to have, to be happy to belong to Baltimore. But for the most part, it was positively received.
Okay, we have another question. Can you share with Coppin State University how we can be more engaged with being a part of the Global Health Equity Network and why it may be important?
Sure. So the Global Learning for Health Equity Network is growing. And we just had a webinar series, and I can certainly share links to that webinar series for people at Coppin that might be interested. We're going to be funding some small grants for people to also develop some new projects around global learning, and we can make sure that that information is also made available in the future once the call for proposals is released. I think global learning is important. Why shouldn't we look around the world and have what's the best of everything for our citizens? We don't have all the best ideas. All the best ideas don't happen in America. There are good ideas all over the world. And so I believe because we struggled for so long to address some of the most difficult challenges, that looking for other places that have successfully addressed those challenges could be quite helpful.
Thank you. I have one more question. Do you have plans to present your findings from this study globally?
I think it's my next steps in the presentation is to do follow-up focus groups with community members and to share more information with more community members about what we learned. And so not so much globally, as important as it is for me to do more locally.
Okay. Thank you. I don't have any more questions, but what I would like to say, thank you so much, Dr. Ogbolu. This was very helpful. We've learned so much. Thank you again.
Okay, thank you. Thanks a lot. And I'll send those links over to you so that you can share.
Absolutely.
Thank you, everybody.
Thank you.
All right, this concludes the program. Thank you.